Hello, and welcome to this explainer. Today, we're going to examine a genuinely critical intersection, the space where education and public health actually meet. We're going to do this by exploring Thailand's Health Literate School framework. You know, for decades, health and education have basically operated as completely isolated disciplines. But as modern academic research consistently proves, one simply cannot fully succeed without the other. This particular framework was developed collaboratively by Thailand's Ministry of Public Health, Mahidol University, and the Thai Health Promotion Foundation. It offers a rigorously structured, highly academic approach to transforming everyday educational institutions into literal engines of public health. Now, to be clear, we aren't just talking about basic hygiene here. We're analyzing a comprehensive, structural integration designed to mold students into proactive health managers. So how exactly do we achieve this? Let's get into it. Okay, let's take a quick look at our intellectual roadmap for today. We'll start by defining health literacy, then move into theoretical models, followed by educational paradigms. After that, we'll break down the assessment framework itself, and finally look at certification and systemic outcomes.
All right, Section 1, defining health literacy, specifically through the interactional theory. To truly grasp the magnitude of this framework, we really have to ground our understanding in established theoretical models. Before we even think about looking at institutional checklists or facility requirements, we need to understand the exact cognitive target we're aiming for. The framework anchors itself on the interactional theory of Kurt Lewin. He defines health literacy not as rote memorization, not just repeating facts, but as a highly dynamic interaction between a person and their environment. Specifically, this framework targets 6 core cognitive and social competencies. A student actually has to develop the skills to access accurate health data, cognitively understand it, actively question and interact with it, make informed decisions, and then adapt their behaviors. But here is the absolutely crucial part. The final competency is learning to advocate for health successes within their broader social circles. It's this profound transformation, going from a passive recipient of health information to a proactive health manager capable of influencing public health policy, that forms the core objective of this entire academic environment.
Let's move on to Section 2, Theoretical Models of Literacy, focusing on Don Newbeam's tiers.
So with those 6 competencies in mind, we can actually measure a student's cognitive progression using a globally accepted theoretical model established by Don Newbeam. And let's see how this builds across 3 distinct tiers. Level 1 is functional health literacy. This is just your basic comprehension and compliance. The student can remember and execute basic directives, right? Like washing their hands during flu season. Level 2 is interactive. Here it gets more complex. The student can synthesize and apply their knowledge to novel situations and successfully exchange health information with others. But the absolute pinnacle? That is critical health literacy. At this tier, the student possesses the advanced cognitive judgment to analyze broader environmental health determinants and actively advocate for systemic change. In the real world, this might look like students lobbying their school boards for better nutritional standards in the cafeteria, or maybe demanding improved air quality systems in their classrooms. The ultimate goal deliberately shifts away from mere compliance to creating critical thinkers who can actually shape public health.
That brings us to Section 3, educational paradigms, and how we integrate health and pedagogy.
Having established those cognitive targets, we now have to look at the macroscopic educational paradigms that guide global health policy. These paradigms dictate the very foundation of this structural framework, and it all rests on a beautifully simple foundational duality: no education without health, no health without education. Think about it. A student's cognitive readiness and academic achievement depend entirely on their physiological well-being. A hungry or sick child simply cannot engage in complex learning tasks effectively. It's just not possible. And conversely, without the structural delivery mechanism of education, individuals lack the systemic training required to navigate really complex personal health decisions throughout their adult lives. When our systemic educational structures ignore these fundamental health needs, they inadvertently exacerbate socioeconomic inequalities. It creates this vicious cycle where vulnerable populations are doubly disadvantaged by poor health and subsequent educational underachievement.
This brings us to a pretty stark contrast in pedagogical approaches. Traditional health education typically relies on heavily siloed subjects. It isolates health into physical education classes with a super narrow focus on basic hygiene. But the Health Literate School framework, it completely dismantles that old architecture. It demands a multi-systemic approach where health literacy is integrated across the entire curriculum. Under traditional models, students might just memorize the food pyramid in a vacuum, but that kind of education completely fails to equip them to navigate these socioeconomic realities of, say, living in a food desert.
True health literacy means a student might use statistics in a mathematics class to calculate community epidemiological trends, or use physical science classes to analyze local environmental pollutants. This networks the school directly into the community, removing health from an isolated academic silo and transforming it into a lived, interdisciplinary practice.
Moving right along to Section 4, the assessment framework, and its 6 core criteria.
So, how do we actually operationalize all these high-level theories into concrete institutional reality? Well, the framework translates these concepts into 6 categorical criteria for institutional evaluation. These are heavily derived from the rigorous Thai Quality Award framework. They span from the executive vision right at the top all the way down to the continuous evaluation of student outcomes at the bottom. This is the structural methodology for molding a traditional school into a health literate school. Let's break these down to see how they function in practice.
Now, what's really interesting about this is how leadership and communication form the absolute top-down structural foundation. Category 1 requires executive intent. School administrators cannot just pay lip service to health anymore. They definitively must integrate health literacy into the school's official vision, its mission statements, and crucially, its budget allocations. Because as we all know in academia and public policy, a vision without dedicated funding is really just a suggestion. The resources literally must reflect the rhetoric. Category 2 ensures this vision doesn't just gather dust on a shelf in the principal's office. Institutional communication demands robust strategies that ensure shared understanding and active policy implementation across teachers, support staff, and the broader community.
Moving over to categories 3 and 4, the focus shifts entirely to empirical data and the student body itself. Institutions must rigorously assess student needs. They have to carefully map out varying socioeconomic backgrounds, familial environments, and baseline health literacy levels. By systematically measuring and managing this data, the school can then design highly targeted academic programs. This is a purely evidence-based approach, ensuring that pedagogical interventions actually meet the unique health realities of the students. Mapping these realities prevents a massive pedagogical failure, the dreaded one-size-fits-all approach. It guarantees that educational interventions are truly equitable and effective for every single demographic within the institution.
Category 5 addresses workforce development. And the framework acknowledges a fundamental truth here. You absolutely cannot build a health literate student without a health literate teacher. The workforce must be systematically prepared and continuously trained. All educators, whether they happen to teach physical education, mathematics, history, or literature, they all must be equipped with a pedagogical capacity to be active facilitators of health literacy within their specific disciplines. It requires a massive systemic paradigm shift in exactly how teachers are trained and supported by healthcare professionals.
And this brilliantly illustrates how this systemic preparation directly enables Category 6, the process of health literacy development. This is where theory finally hits the classroom floor. It involves deliberate, empirical environment design and employing highly participatory learning strategies. Specifically, the framework highlights the PIR method: participation, investigation, and reflection. Participation requires active engagement, not just passive listening. Investigation tasks students with mapping real-world variables, things like assessing the ventilation systems in their own school buildings or managing risk protocols during a global pandemic. And reflection ensures they synthesize these practical findings to build durable, critical thinking skills.
Finally, Section 5, certification and systemic outcomes. Let's talk about measuring success.
Now that we've examined all the structural criteria, how are these institutions officially recognized? And what is the resulting macro-level impact on public health? Schools are rigorously evaluated and granted certification across 3 progressive levels. And notice how these intentionally map directly back to Don Nutbeam's theoretical tiers we discussed earlier in the explainer. A Level 1 initiative certification means the school systems successfully produce students with functional health literacy. Level 2, the advanced certification, shows a huge leap forward where pedagogical systems ensure students exhibit interactive health literacy. And finally, Level 3, the award tier, is achieved only when the institution reliably produces students with critical health literacy. These are students who are not only managing their own well-being, but are generating a measurable positive societal impact in their broader communities.
So the crucial point is that the ultimate goal of this framework completely transcends merely hanging a nice certification plaque on a wall. The macro-level impacts are what truly matter. Success is defined by empirical epidemiological reductions in actual health problems among the student body over time. It's measured by statistically significant positive shifts in structural health determinants and incredibly sustainable changes in the cultural and pedagogical practices within the school itself. It is really about permanently altering the behavioral and educational ecosystem of the institution to foster lifelong health resilience.
Which leaves us with a pretty massive systemic question to ponder. This structural framework proves unequivocally that public health and educational pedagogy are intrinsically linked. If educational institutions are indeed the most effective, structured engines for generating public health literacy, how must our national policies evolve? How do we break down the rigid legislative and budgetary walls to fully integrate these two historically isolated systems? It's a profound systemic challenge, one that policymakers, academic researchers, and educators absolutely must confront if we are going to secure the well-being of future generations. Thank you so much for joining me for this explainer.